Good evening. Thank you for joining us for the first of an 8-part webinar series, The Essentials in Oral Health, exploring topics in preventive dentistry and periodontology. This series is sponsored by the Johnson & Johnson Company and offered exclusively to you as members of the Next DDS user community. I want to thank the Johnson & Johnson Company and the team from the Next DDS for allowing me the opportunity to be your speaker for this seminar. My name is Christine Hovliaras, and I'm your speaker for the first webinar. It's my pleasure to connect with you online this evening. I've been a dental hygiene professional for over 30 years with experience in clinical, educational, and research career positions in both academia and in industry. I am president of Professional Savvy, LLC, an oral care consulting, professional marketing, and continuing education company in New Jersey. My expertise includes clinical dental research, sales training, professional sales, professional marketing and relations, as well as being a national and international speaker, consultant, and writer. I'm also the author of the new 3-volume set of textbooks for dental hygienists entitled Savvy Success, Achieving Professional Excellence and Career Satisfaction in the Dental Hygiene Profession. I'm also adjunct faculty in the Department of Dental Hygiene at New York University College of Dentistry. I was previously editor-in-chief of the American Dental Hygienists Association magazine called Access from 2005 to 2008 and editor emeritus in 2009. I currently work as a registered dental hygienist in a prosthodontic practice in Morristown, New Jersey. My presentation tonight is titled Improving Periodontal Health by Disrupting Dental Plaque Biofilm, and I'm excited to share this information with you in just a few short minutes. But first, a couple of housekeeping items I'd like to cover. The presentation will run approximately 45 minutes, and you can pose questions using the toolbar at the bottom of your screen. We'll collect your questions and answers, as many as possible. We'll try to answer just after the presentation. So let's begin tonight's webinar on improving periodontal health by disrupting dental plaque biofilm. Over the past 20 years, research has been conducted on the oral environment and the importance of reducing dental plaque biofilm and inflammation in the mouth to provide an overall improvement in oral hygiene and oral health in patients. Tonight's webinar will cover 5 different objectives. The first is to identify, The first is to identify the oral microorganisms that develop in the human mouth. The second is to define what dental plaque biofilm is and discuss the stages of its development in the oral cavity. Identify where plaque biofilm develops and oral diseases associated with its presence. The fourth strategy is to share strategies to manage plaque biofilm to promote overall improvement in oral health and wellness in the patients that you treat. And number 5, we'll discuss the importance of the patient oral health risk assessment, and we want your involvement in 2 case histories that we'll discuss, and you'll be able to address some questions that we're going to answer with these 2 patient case histories. When we look at the human mouth, it is colonized with an abundant, complex microbial community of microorganisms. And there are approximately 700 plus microorganisms that are in the mouth. They develop on the soft and hard tissues, the tongue, the teeth, implants, on fixed also and removable appliances, and also in saliva and gingival curvicular fluid that is below the gum line. Some of the oral microorganisms that we referred to previously as dental plaque and now as dental plaque biofilm include the following: streptococci, diplococci, staphylococci, bacilli, coccobacilli, fusiform bacilli, filamentous bacilli, spirochetes, and also vibrios. When we look at dental plaque biofilm, it's a very, very complex three-dimensional community. It's a highly organized structure of all these different microorganisms that form together, and they use several different interactions. They interact by physical, metabolic, and also molecular interactions, and they adhere to surfaces where there is moisture and also nutrients. This is an artist's depiction of what dental plaque biofilm would look like on the teeth. As you can see down below, these little white pegs are the teeth, the enamel of the teeth, and here's your matrix of biofilm forming on top. Bacteria in the biofilm will maximize their nutrients for existence, and they do this to keep the community very healthy, to protect their matrix when it's under attack, and also to relocate to develop new biofilm communities in other places within the oral cavity. The first stage of dental plaque biofilm development is the acquired pellicle adhesion stage. Pellicle will serve as the initial site of attachment for planktonic bacteria, which is the first stage of biofilm development. Salivary proteins and peptides promote bacterial adhesion to oral surfaces. As we know, and think about it when you're in dental school, after a person has had their teeth cleaned, we know that that acquired pellicle forms right away on the tooth surfaces. The first microorganisms to be a part of that pellicle, of that little community, are gram-positive aerobic cocci, and they include Streptococcus mutans and Streptococcus sanguis. This next photo shows the acquired pellicle adhesion, and you can see the Cockle community of bacteria here. Stage 2 is the colonization and bacterial growth. In this stage, planktonic microorganisms will multiply and grow, and they form almost stratified layers against the tooth surface. What we'll see is filamentous microorganisms growing on the surfaces of the cockle, those round microorganisms, and begin to replace the cocci. In the next picture, you will actually see the colonization and bacterial growth stage. Here's the cocci at the bottom, and here are the filamentous microorganisms at the top. They will take over those cockle or microorganisms in the process of the development of biofilm. Stage 3, as we know, is the microorganisms in the community will begin to secrete extracellular polysaccharides to form this matrix. And this matrix is very strong. It's also water insoluble, and the matrix contains both saliva and polysaccharides, which are produced in response to sucrose and fermentable carbohydrates. What happens is these polysaccharides further facilitate plaque adhesion through their sticky composition. They also trap nutrients, which are a food source for the bacteria in this matrix, and contribute to other protective functions in the biofilm. Some of the filamentous microorganisms that are in this matrix include rods and fusobacterium, and these usually appear at days 4 to 7. During days 7 to 14, we see a different stage of microorganisms coming in called vibrios and also spirochetes, and they will develop along with gram-negative anaerobic microorganisms as well as white blood cells that will be in the biofilm matrix. We'll also see the beginnings of gingivitis develop as well. This next picture shows a transmission electron micrograph of a section of mature plaque underneath the microscope. What I want to point out are two features. First is note, if you can kind of see this, the densely populated, base of this matrix of bacteria. And then above that, we have more rod-shaped microorganisms being a part of the matrix. this next slide, okay, we see a depiction of a human's mouth, okay, and as we see along the gingival margin, we do have some inflammation definitely occurring, okay, redness, I should say. You can see the beginnings of the plaque formation here, and this patient could have also has some hypertrophic, hyperplastic, I should say, gingival attachment level. And this could be due to some of the medications this patient could be taking. But we're actually seeing it depicted in a human mouth, and that's what we wanted to show, was dental plaque biofilm at the gingival margin. Stage 4 is the formation of the dental biofilm matrix. As this bacterial growth process continues, this matrix connects the bacteria. The dental biofilm is a community of functioning, different living species that are all, together in this matrix. What we also know is that the bacteria on the inside of the dental biofilm will become slow growing or static, which is kind of interesting when you think about it, the intricate details of the biofilm. What we find is deep within the biofilm, some bacteria will die and cell walls will become disrupted. There is also loss of cytoplasm of the cells, and the bacteria near the surface of the biofilm will remain intact and alive. This next picture shows the formation of the dental biofilm matrix. What we see here are, when you think about plaque, you don't think of it in this in-depth terms as we're talking tonight. And that's why the biofilm is such an interesting and interesting matrix when we think about it in these terms of the stages of biofilm. What we find is when this biofilm matrix is formed, we have toxic wastes of one species of bacteria are the resources of another species of bacteria. So some surface bacteria will detach and form new biofilm colonies. We also will possibly see the formation of calculus beginning to form with crystals in this interbacterial matrix, and gingivitis will definitely be clinically evident by days 14 to 24, and the biofilm will be composed of Vibrio, spirochetes, and filamentous bacteria. As this community of biofilm matures, it will change shape, and sometimes it's looked at as a mushroom-like appearance. So you'll see it'll be with a slime base, and it has channels where fluid movement will occur within the oral cavity. The fluid channels will also help to distribute nutrients, remove waste, and allow these planktonic bacteria to leave the matrix and form new biofilm communities elsewhere within the oral cavity. Stage 5 is when we see the dispersion of the dental biofilm, and this is where the cells from the biofilm will disperse from that matrix and go to another part of the oral cavity to begin that biofilm life cycle. So it's kind of a never-ending cycle of this plaque biofilm development occurring through these stages. So hopefully that was clear to most of you. It's kind of technical, sorry about that. We'll make it a little more interesting as we continue to forward now. So let's talk about where this biofilm will develop. There are two examples in the mouth where the biofilm will develop. As the supragingival plaque grows undisturbed along the gingival margin, it will extend subgingivally. This will lead to gingivitis and also oral inflammation in the mouth. When we talk about the two examples, we will talk about supragingival plaque and subgingival plaque. In supragingival plaque, this is attached to the teeth and along the oral mucosal margin. Bacteria are primarily gram-positive cocci and rods, with very few motile species. The bacteria associated with periodontal health are the next three, which is Streptococcus mitis, Actinomyces species, and also Streptococcus sanguinis. Subgingival plaque is attached below the gingival surface of the margin in the gingival crevice and the periodontal pocket. So what we find here is that bacteria associated with gingivitis are gram-negative spirochetes and motile rods, and these include Fusobacterium nucleatum, Prevotella intermedia, Treponema, and Campylobacter rectus. Now, once we know where this plaque biofilm develops above and below the gum line in supragingival and subgingival plaque, the type of diseases that they form are two types. Number one is dental caries, and number two is periodontal diseases that the biofilms will associate with. Dental caries, as we know, is the solubilization of tooth mineral by acid production by certain bacteria that adhere to that tooth structure in bacterial communities known as biofilms. And what we find are the microorganisms that are associated with dental caries are Streptococcus mutans and Lactobacilli. What we find is there is a loss of tooth mineral from the action of acid formed by these plaque bacteria after ingestion of foods containing fermentable carbohydrates occur when a person is eating. This mineral is often replenished by the saliva, as we know is a mineral source in the oral cavity, and this mineral source helps between meals to replenish that loss of mineral. When more fermentable foods are eaten more frequently, the low pH in the dental biofilm is sustained, and a net loss of mineral from the tooth structure will occur. What we find is the more acidic microorganisms are the strep mutans and also the lactobacilli, because they store polysaccharides and continue to secrete acid after the food has been swallowed. Next is periodontal diseases, and many of us know about the diseases of periodontitis. When we look at periodontal infections, they involve anaerobic bacteria such as Treponema denticola, Porphyromonas gingivalis, Actinobacillus, Actinomycetum comitans, which are responsible for the localized juvenile periodontitis cases. What we find is that dental biofilms have various compounds such as amines, toxins, enzymes, and also antigens that elicit an inflammatory response that is responsible for the loss of periodontal tissue, pocket formation, and loosening and loss of the teeth. This next slide shows two figures. One is an intraoral shot of a 14-year-old African-American woman who has juvenile periodontitis, and the shot to the right is the radiographs that were taken of this patient. As you can see, with juvenile periodontitis, we're seeing bone loss on the mesial of tooth number 3, on the mesial of tooth number 19, and also on the mesial of tooth number 30. Dr. Roy Page and Dr. Stephen Offenbacher quote the following: "The meticulous and regular removal of dental biofilm is important for oral health." And I know this as a practicing hygienist over 30 years working in many different practices in the periodontal field, in the periodontal practice, in the general dental practice, and now in a prosthodontic practice. And as we know as dental professionals, it's very, very important. Our goal, working as a team with the hygienists and the assistants, is to educate patients and assist them in the importance of knowing what the oral systemic disease connection is, so that they're able to adequately remove biofilm to improve the oral health of the gingival tissue. And as we know, inflammation in the mouth can go elsewhere within the body, as the research that has been conducted on that oral systemic disease link. Okay, so now we know about the stages of biofilm. We know where it forms. We know what diseases it affects, or it causes. Now we have to look at strategies to remove biofilms. And I think the easiest, most fastest way to remove them is mechanical plaque removal, and this is highly important. And as we know, oral hygiene procedures are a key priority to improve oral hygiene and oral health amongst our consumer population. Everyone, ideally, this is the goal of every hygienist that you probably talk to will say this, is to floss once a day before bedtime. And to motivate patients to do that is sometimes very difficult, and they're sometimes non-compliant with it. And also brushing a minimum of twice daily, once in the morning and once in the evening before you go to bed, is essential to removing dental biofilms along the gum line and interproximally to prevent dental caries and gingivitis from occurring. Also, many of us know, consumer research reports this, and that you may be aware of this as well, that most people do not brush their teeth for any more than 1 minute. Usually it's 45 seconds, which isn't usually a complete toothbrushing. According to the ADA, they suggest that dental professionals recommend that their patients brush at least 2 minutes per day. So consumers really need to be educated by you as new dentists coming out into the field, working with your dental teams in an office on performing adequate oral hygiene procedures at home to improve their oral health. Dental professionals also must work with all levels of dental and periodontal needs of their patients and help them to diagnose what each patient needs to provide them with the adequate care for optimal oral health. When we talk about mechanical plaque removal, we look at several different options. Number one, definitely a manual, and now also an electric toothbrush. We know that an electric toothbrush is of prime importance based on some of the data that Cochrane Collaboration has published. Number two is when you're brushing, as we all know, okay, it sounds very simple and not exciting, but it's very, very important to brush at a 45-degree angle so that the toothbrush bristles reach the gum line and also are able to reach a little bit below the gum line in that gingival crevice so that you're able to remove some of the subgingival plaque that may be there, usually 1 to 3 millimeters below the gum line. Number three is to actually do number two, I should say, is flossing and using interdental cleaning devices. Now, due to the fact that so many patients do have implants, you're having to use different interdental cleaning devices, such as proxy brushes, such as rubber tips, stimulants, toothpicks, in order to clean around these devices. And what we also find too is that we need to motivate our patients of the importance of flossing and toothbrushing. And it should be a positive experience. It shouldn't be like at the end of the day, you're exhausted, you can't wait to get into bed, and you don't want to do the flossing. We have to get them excited that they need to do this because there's a reason for it. So we can prevent this biofilm from occurring. We can reduce inflammation in their mouths and make them healthier from an oral care perspective, which leads to a total better body experience of wellness. And lastly, we also look at oral irrigation devices that can also be used to flush out between the teeth and below the gum line, especially for those patients who do have braces and have a lot of plaque buildup around that area. Here's just a picture. This is not of flossing, but of getting ready to floss and also to use the toothbrush, whether it be manual or electric. Now, some of the strategies that we can do in the dental office are very, very important, and your dental hygienist plays a primary role there, as well as yourself if you're also doing the scaling and root planing. Optimal goals for periodontal treatment are to stop the progression of the disease, and that's to obtain healthy pocket levels and also gain attachment levels. And with this, scaling and root planing play a major role. What we find is that in supragingival and subgingival scaling, these are the standards for non-surgical treatment for periodontal disease, as well as the use of local and systemic antimicrobial therapy. Our goal for the dental hygiene department is really to, on the root surfaces, is for those root surfaces to be smooth upon completion of scaling, thereby reducing recolonization and subgingival plaque biofilm adhesion and retention to that surface. We also, dental calculus provides a distinct, prominent, and rough site for the adhesion of bacteria and biofilm retention, and this also contains endotoxins, which are in gram-negative bacteria, which cause inflammation to occur. When we use supragingival and subgingival scaling, this can be conducted, and let me go to the next slide, with hand instrumentation or with ultrasonic scalers. And some clinicians, like myself, will use a combination of both of those. I'll use ultrasonics if there's a lot of calcified dental plaque, calculus, as well as will fine scale to remove any type of, fine calculus or biofilm removal. So I like to use both. And it depends on the patient that you're treating as well. Some of our older patients in our prosthodontic practice don't like the use of the ultrasonic. So I'll do the hand scaling with those patients. When we use ultrasonic scaling in the office, it offers many advantages to the dental hygienist. As many of you know, most hygienists may be on a 45-minute to an hour prophylaxis schedule. I'm on an hour schedule with each patient, and I do need that hour based upon all the things that I do for my prosthodontist in that practice. Ultrasonic scaling offers the following advantages versus hand scaling. Number one, it's less fatiguing to the clinician. It's less time consuming. We're able to remove, 1 to 5 millimeters of calculus within seconds. It also does less tooth substance loss as well. It doesn't affect taking away the tooth structure. It also provides irrigation of the pocket during instrumentation because of the water, used to cool the heated tip. And it also provides for superior access to tight subgingival areas during scaling. So when we talk about ultrasonic scaling, there's two types of ultrasonic scaling devices. There's magnetostrictive, and piezoelectric. Magnetostrictive uses a movement and frequency of 25,000 to 30,000 cycles per second and places the insert into the handpiece. The power is distributed to all surfaces of the tip for removing deposits. It usually uses water, power, and tuning. And when I was back in a dental hygiene school in the early 80s, we used the Cavitron, and that's an example of the magnetostrictive device. The piezoelectric has a frequency of 25,000 to 50,000 cycles per second. These scalers usually contain quartz discs or ceramic plates in the handpiece that vibrate rather than the vibrating metal stacks that the magnetostricto insert uses. A linear motion of the tip occurs, and the two lateral sides of the tip are what provide the working stroke to remove calculus and other debris. Okay, so now we're going to talk about chemotherapeutic agents for helping to reduce plaque biofilm. And when we describe a chemotherapeutic agent, it's really a chemical agent or drug that's used to treat a disease or counteract a host response to the disease. And this is something that's really kind of true to my heart, the second paragraph, which basically states that it's so important for you when, now as you're practicing as a student dentist, and then when you graduate and become a dentist, it's so important for you to read the literature. You need to know the research that has been published on the products that you're going to recommend in your practice for your patients to help them fight and reduce dental caries, gingivitis, and plaque. So it's very important that you're reading the journals and the magazines, and you're looking to make sure that the clinical research is done effectively and it's valid research and it supports the claims that the product is making. So you really need to be up on the literature so that your whole team are recommending the right products for your patient's needs, oral care-wise. We're going to discuss 5 different categories of antimicrobial ingredients. The first are bisbiguanides. The example of that would be chlorhexidine digluconate. The second will be phenolic compounds. We'll talk about the fixed essential oils and triclosan. The third category are quaternary ammonium compounds, which include cetylpyridinium chloride and domophene bromide. The fourth category are called halogens, which includes fluoride, and the fifth category are called oxygenating agents, and these include hydrogen peroxide and chlorine dioxide. So it's important that you know about these categories of chemotherapeutic agents so that when you're making a recommendation in the dental school clinic, you're making the adequate recommendation for that patient's needs. The 2 most widely recommended antimicrobial, agents are the essential oils, as we know them to be found in Listerine antiseptic, and also chlorhexidine. These are the 2 most widely available used chemotherapeutic agents. We also know that there are generic mouth rinses that do have the ADA seal of acceptance, but there are no published studies that were conducted to show the efficacy of these generic rinses in reducing plaque and gingivitis. So for those patients who are looking at the cost of a product, it's to your benefit to have them, be recommended a product that has the ADA seal of acceptance with the published research behind it. So for that instance where we would recommend Periodontal or Listerine antiseptic to a patient for plaque and gingivitis efficacy. As we know, the ADA seal, through the American Dental Association, they actually stopped to do the seal program for prescription products in January 1st of 2008. So chlorhexidine mouth rinses do not carry the ADA seal for this reason. The first category we'll talk about is chlorhexidine. And what we know about with chlorhexidine is it has been shown to reduce dental caries, dental plaque, and gingivitis in humans. It's one of the most widely researched chemical agents on the market with a broad spectrum of activity against both gram-positive and gram-negative supragingival and subgingival plaque bacteria and fungi. What chlorhexidine does is it binds to the salivary mucins to help reduce pellicle formation, inhibiting the colonization of bacteria. As we know, if any of you have used chlorhexidine with some of your patients in the dental school clinic, there are disadvantages. It does cause tooth staining, so the patient does need to be polished adequately. It will cause calculus formation to occur, and some patients will have an alteration of taste perception. And we also know that chlorhexidine can be inactivated by dentifrices that contain sodium lauryl sulfate in their ingredients. So what we would recommend that you do is basically have your patient wait at least 30 minutes between toothbrushing and then rinsing out with the product. Our phenolic compounds are what we're going to discuss next. So we're first going to talk about Listerine. And what we know is this is the longest antimicrobial agent that has been available worldwide for over a century. Listerine was the first non-prescription mouth rinse to be accepted by the ADA Council on Scientific Affairs for the controlling of plaque and gingivitis in 1989. We know that the essential oils, through the clinical research that's been conducted, kill microorganisms by disrupting the cell membrane and inhibiting enzyme activity. It also prevents bacteria from aggregating with slow bacterial multiplication. Okay, so the bacteria are not growing as much. And it also extracts endotoxins from gram-negative pathogens to help reduce the accumulation of bacteria. The second part of this that we're going to talk about, let me just pop back for 1 second. I do want to mention one study that was recently conducted on Listerine's effect on biofilms. This was a study where biofilms were grown in the laboratory over a 60-hour period and then were subjected to a twice daily treatment of not only Listerine but also chlorhexidine as a group, and also cetylpyridinium chloride. And what we found is there were 5 hours between the treatments of those biofilms being exhibited to those different treatment groups. And what we found is that Listerine antiseptic exhibited a deeper penetration in that biofilm and helped to kill that biofilm. It showed parity compared to chlorhexidine, but it did superior kill versus CPC, which is cetylpyridinium chloride. And what we find with Listerine, it does provide a 56.3% reduction in plaque and a 29.9% reduction in gingivitis for those patients who do brush, floss, and rinse with Listerine, as compared to those patients who brushed and rinsed with a control mouth rinse. So it is beneficial to patients who do have gingival inflammation. The next component of the phenolic compounds is triclosan. And triclosan is a bisphenol with a broad spectrum of activity. It is effective against both gram-positive and gram-negative bacteria. It also helps to bind to salivary mucins to reduce pellicle formation and inhibit the colonization of bacteria. However, by itself alone, it's not substantive. However, it does have oral retention, as we know, when it's enhanced by copolymers such as methoxyethylene and malic acid, also known as gantrez. It has an effective anti-plaque and anti-gingivitis capabilities in toothpaste and also in mouth rinse products with 0.3% triclosan and 2% gantrez copolymer and 0.3% triclosan and also 1.125% gantrez. Next is the quaternary ammonium compounds, and with these compounds we see that they interact with the cell membrane of the bacteria and they affect their permeability. This results in a loss of cell contents. However, it does have a low level of substantivity, but it will bind to oral tissues as well. Some of the disadvantages of quaternary ammonium compounds such as CPC, which is cetylpyridinium chloride, and domophene bromide, are that they sometimes do cause tooth staining. They may cause a little bit of burning of the soft tissue depending on the patient, and it can cause an increase in calculus formation and also taste alteration to the patient as well. Our next and fourth category are the halogens, and this is the fluoride. And we know by all the document research that's been done over hundreds of years here that fluoride is a well-researched caries preventive agent, but its role in the prevention and control of plaque is less documented due to the research. We know that stannous fluoride is a chemical molecule with a fluoride component that is in combination with tin. And we know that when tin may enter the bacterial cell wall and impair its metabolism. However, because of its lack of stability in storage as an ingredient and increased staining properties, it is of questionable efficacy in reducing gingivitis. The other component of fluoride that we'll discuss briefly is sodium fluoride, and this has been shown to have some anti-plaque and anti-gingivitis activity. Last are the oxygenating agents, and we know that the hydrogen peroxide is one of them, which has a long history of oral use for temporary oral wound healing. But for chronic use, when it's used in higher concentrations, it may also cause soft tissue damage and other side effects. Hydrogen peroxide used as a plaque and gingivitis agent has been limited. Low concentrations of hydrogen peroxide in mouth rinses have been shown to be effective in definitely reducing tooth stain and whitening teeth when used twice daily. The use of chlorine dioxide in mouth rinses for the control of oral malodor, plaque, and gingivitis has not been supported by any published scientific data. So that gives you a little bit of an overall of the different types of chemotherapeutic agents that you can consider to use with your patients. And again, as a dental professional, a consistent and important approach to product recommendations in the practice is an evidence-based scientific overview. And as I said before, it's very important for you and your team to understand the literature and to know what claims are being made about these products, so that you are, you are offering the best products for your patients to help them improve overall plaque and gingivitis. In conclusion to this review, the most published research has been on the bisbiguanides and the phenolic compounds. And again, it's necessary for you to assess the cost of the product, look at the clinical efficacy of the product against dental biofilm to reduce plaque and gingivitis, and note that there are no safety or side effects that will occur if you or your team recommend a product to your patients. All right, this is our last part of the program. Hopefully we're doing well on time, so Rich Groves from the Next EDS team will let me know. It's very important to, as a dental student, to conduct a patient oral health risk assessment evaluation with each patient that you treat. This includes each person, as you know, is their own person and has different needs from other patients that you may treat in dental school. So by conducting this thorough patient oral health risk assessment evaluation, this will help you determine what their medical and dental needs are to assist you in putting together an adequate treatment plan to provide the right preventive and dental care for each patient. So let's go to the next slide to see where we begin in this risk assessment evaluation. Number one, okay, as we all know, each patient that you treat always fills out a complete medical history. And because patients are living longer now, we need to know what types of, medical issues are they currently dealing with. So they're going to complete the medical history. You're going to thoroughly review the medical history. And what's highly important is that when you're doing this, you question the patient in a very professional and a very comfortable way so that they feel that they have some type of a nice collaborative relationship with you as a dental professional. And this is important because when you do this, you're going to be able to obtain some valuable information from them regarding their current medical issues or diseases, what medications are they currently taking daily, Are they allergic to any medications? This is highly important for you to know as a dental professional. Are they allergic to any antibiotics? We're seeing a lot of that with the allergy to penicillin in our practice. And determine if pre-medication is required prior to that dental appointment. Step 2 is that we're going to conduct next an oral health assessment, and this is the dental caries assessment. This is the first step in determining if the patient has a risk to this oral disease. We need to determine, as most of you may know, a lot of patients do not have dental insurance, okay? And they don't see sometimes the need of the importance of seeing their dentist and their dental hygienist. The dentist for an overall oral care evaluation, excuse me, to assess the oral care needs in their mouth, as well as the hygienist for a preventative cleaning. So we have to determine if the patient has a dentist or a dental home. Just going to take some water. Number 2, it's important that they have a dental home to help them reach a higher level of optimal care so that you can take care of dental issues that are occurring or can be prevented. Excuse me. It's also important, I have to take another swallow. I get a little dry. I'm just having a problem here. Oh. Okay. It's also important to determine if they need x-rays. And that could be full mouth series, bite wings, or panoramic. We also have to determine if new x-rays should be taken. And you need to conduct a thorough extraoral examination to determine, to do this by palpating the neck and throat glands, and intraoral examination to evaluate the intraoral situation in each patient's mouth. It's important to also have your dental assistant to assist you in completing this dental charting form, and that's to determine present and lost teeth, to determine if teeth have been decayed, to determine if any restorative or preventive services need to be scheduled. Hopefully my voice is coming back. Sorry about that, gang. Thirdly, I should say, it's important to do a periodontal oral health assessment as well. And with this, we have to conduct a thorough probing examination of the entire mouth. It's very important that the American Academy of Periodontology recently said that every patient should be examined for a periodontal evaluation at least once a year. And this is really important that you do this with your patients. Identify if the patient does have gingivitis and what level of gingivitis do they have. Identify if the patient is at risk for periodontal disease. It's very important to record all pocketing on the periodontal evaluation form. And this is 6 sites per tooth. It does take time, but it's very important. Determine when the patient has had their last professional cleaning appointment and discuss what the current findings are with the patient. Also, reinforcement of oral care habits, and determine when the next cleaning appointment is needed. Okay, and again, we know reinforcing proper oral hygiene and determining if they need to have more frequent cleanings. Step 4 is oral cancer. And this is very important because we have seen an increase in oral cancer over the past 10 years. The oral cancer assessment is vital to determine if the patient has any oral habits. Do they smoke? Do they use chewing tobacco? What type of frequency and quantity do they use? Are they a drinker, and how much do they drink? We don't think this is important, but it really is. Has oral cancer occurred in their family? If it has, we need to, it's so important that your dental school does have either a Velscope evaluation or another oral cancer device that you can use to actually assess, to do a complete oral cancer evaluation intraorally. And identify if the patient is at risk for oral cancer. So this patient oral health risk evaluation, the 4-step process, is highly important that you do with each patient that you treat. All right, now we're going to do some patient case histories. The first one, and Rich and I want you to participate in this. He'll be getting your answers below on our toolbar here. So the first one is patient case history 1. Her name is Tiffany, and she's a 50-year-old female patient. She had a hip replacement this past April, and she just finished anticoagulation medication at the end of May. She's currently taking blood pressure medication and cholesterol medication, and she also has an allergy to penicillin. So that's her patient overview. Some of her oral issues that have occurred is that she complains of bleeding gums when toothbrushing. She uses a manual toothbrush. She uses a fluoride toothpaste and no mouth rinses. She hasn't had a cleaning in over a year, and she also has dry mouth in the morning, and she's also a nighttime snacker. So that kind of gives you an overview of this patient. So next we're going to go to the next slide. So I want you to answer this on your toolbar for us, because we're going to go through this. Number 1 is, what medications is Tiffany currently taking? If you could write those down. Number 2 is, what medications did Tiffany finish taking? We know that her surgery has occurred in April, and that we know is a hip replacement. So what antibiotic does Tiffany have an allergy to? And should Tiffany be pre-medicated? Yes or no? This is highly important with patients who've had hip and knee replacement. If you do pre-medication, what antibiotics should you recommend? And what steps need to occur prior to Tiffany coming in for her dental appointment? So the first question, what medications is Tiffany currently taking? What are they? So we know from what we've just been told, she's been on what? Blood pressure and also cholesterol medication. Number 2, she just finished taking anticoagulant therapy. And most of us probably know that the reason that they prescribe anticoagulant therapy after hip replacement is to prevent blood clots from occurring in that patient. We know she's had a hip replacement, and we know that she's allergic to penicillin. So does anybody know what you would prescribe to this patient if she has an allergy to penicillin? So if you could kind of put that through to our next DDS team, that would be highly important. Does anybody know what that would be? Rich, do we have anybody that has answered that yet? Right, exactly. Actually, clindamycin. Clindamycin would be, let's go back one here. Clindamycin would be the one that most dentists would recommend for a patient with an allergy to penicillin. Excellent. Okay, so I wanna just keep it going, so because I know we're on a time schedule. All right, so those are the issues there. She would require pre-medication, definitely, and that would be coming through her orthopedic surgeon as a request prior to any dental treatment. So let's look at the oral issues. What oral issues is Tiffany actually complaining of? Okay, so let's go back to that. What oral issues are coming in? We're seeing, and what are there any other oral care issues she should be concerned about? So she said that what oral care issues do you remember? We saw bleeding gums, right? And she also has dry mouth in the morning. Also, too, what oral hygiene practices does she do every night? Okay, so what did she say? Did she floss or did she toothbrush? And we found, right, that she was just using a manual toothbrush with a fluoride toothpaste. So that's the answer to question number 2. For question number 3, what oral hygiene practices doesn't she do every night? And why do we have bleeding gums? So that's the answer to that, and all of you know what that is. That's actually going to be that she's not doing any flossing. And when you're not doing any flossing, you're going to have some biofilm development. And she's not using any type of mouth rinse usage in addition to that. So for question 4, what should you be concerned with regarding her oral care habits? What's some of the things that come to your mind for her? Okay, so when we look at her oral care habits, she's number 1, her gums are bleeding. She's not flossing. She's also a big snacker. Oh, this is really good, especially at night, depending on what she's eating, right? Think about some of the things that people eat. So if she isn't flossing food out, she's not flossing biofilm out, that's caught between her teeth, and she also has dry mouth, which is not good because the bacteria are going to go crazy in that dry mouth. For question number 5, do you think her caries risk assessment will be low or high? And I know all of you know what that is, okay? If she's a nighttime snacker, right, depending on what she's eating, hopefully she's not eating taffy. We don't know if she's having chips or pretzels. Her risk assessment will probably be a little bit higher depending on what she's eating, especially if she's not doing any type of flossing. Okay, now as far as number 6, will she have gingivitis? What do you think? I would think if she's got the bleeding gums and she's not flossing, as a practitioner, probably she would have, yes, she would have gingivitis. When we ask about periodontitis, it would be actually probably assessing that through the oral care assessment to determine if pocketing is occurring. For question number 8, what would you recommend as oral care products to Tiffany after she comes in to her oral evaluation and cleaning appointment? If she's got a gingivitis problem due to bleeding gums, maybe an antimicrobial toothpaste plus an antimicrobial mouth rinse may be recommended by you or the dental hygienist that you work with. Other issues that should be addressed with Tiffany would be maybe more frequent intervals to get her cleanings done. Instead of 6 months, maybe more 3 or 4 months. And then also possibly addressing her dry mouth issue. Okay? Let's go to the next case history because we're almost to 9 o'clock. This is a 75-year-old male, Robert. He suffers from mitral valve prolapse for over 10 years, needs to get in to see a dental student at the dental school because he's suffering from tooth pain. We'll just zip through him real quick. He has type 2 diabetes. He went through prostate surgery in 2010 and recovered, and then suffered 2 mini strokes. He also has medications he's taking for heart disease, diabetes, high blood pressure, cholesterol. So he's got basically pain in tooth number 2. He avoids chewing on that side. He had a history of periodontal surgery. He hasn't seen a dentist since 2011, probably some of the patients you may be treating at the dental school. And he only brushes his teeth with a non-fluoride toothpaste. He does not floss, and he uses vinegar to rinse his mouth out each day. This does happen in private practice, people, so it could be an occurrence that happens with you. Let's go to the next slide really quickly. As a dental professional, what's your biggest concern with Robert? Definitely, he's got mitral valve prolapse. He's had a history of strokes. Number 2, what medications is he currently taking? Anticoagulant, diabetic, high blood pressure, and cholesterol. He did suffer from prostate cancer back in April of 2011. He has no allergies to penicillin. Future concerns must be that he has to have an examination with a cardiologist from a medical perspective once a year, must maintain a regular professional exam, and cleaning with a dental professional every 6 months. And the cardiologist and the dentist should have a collaborative relationship working together. We'll just zip through this real quick so we can get to the end. Again, his oral issues are he's suffering from pain in the second molar. He's not chewing on that side. Dental x-rays should definitely be taken of tooth number 2 to determine if it has a fracture in the tooth or maybe some endodontic involvement. He's brushing with a non-fluoride toothpaste. He's not flossing. He also has had previous periodontal problems. Is this an issue? Major issue. He also needs a thorough oral exam, and x-ray should be taken to determine future caries issues. We need to assess the gingival tissue to determine if pocketing has occurred or is still occurring. And his major tooth, pain in tooth number 2, will be an examination with an x-ray to determine what problem is occurring. Our goal tonight as dental professionals is to assess each patient as an individual, conduct a twice-yearly oral examination, conduct radiographs for preventive care and assessment, evaluate periodontal, dental, and restorative health, and identify the appropriate treatment plan to provide optimal dental and periodontal care to the patients that you treat. You work as a team in a very proactive and engaging way with trust, respect, and value for your team, the dental assistant, the dental hygienist, and your front office team. This will provide the highest level of professionalism to you and the patients that you care for in your practice. Also, too, it's very important to work with the patient in a calm and reassuring way so that you're building a level of trust with them and communication, and that your team is providing the best care for enhancing the oral care of the patient to reduce oral diseases, to provide the optimal health and wellness for your patients. I want to thank you for taking time from your busy dental school schedule to be a part of this webinar tonight. I also want to thank Johnson & Johnson Healthcare Products Company and the Next DDS for allowing me the opportunity to conduct this webinar with you. I want to thank you, and I wish you continued success in your career. I also, at closing remarks, I've enjoyed my time with you. Please be sure to enroll in the Next DDS. Tell a friend or a colleague that you know to join us in the next few weeks for the second presentation in the Essentials in Oral Health series. We're going to close with a quick survey. Will you please provide your feedback before you leave the session? Thank you so much, and have a great evening. Thank you so much for joining us again. All right, have a great night. Thank you.